Okay, so let's take just a couple of minutes to talk about the exam itself. So here are the results for the first exam. Pretty standard. This is maybe just a touch lower in the mean than we saw last year, but the median is almost exactly the same. So the mean on this exam was 71.41. There's your standard deviation. The median 73. High score, we had a couple of students get 100 this year. So if you're listening, congratulations for that. And as I said, after each exam, what I'm going to do is give you a sense of now, what the score on your exam means with regard to your standing in the course. And this is approximate, but it is pretty close. So what these numbers mean here is that if this course were to end tomorrow, right, for whatever reason, this is the grade, would be the marking rubric that would apply to the course at this point in time. So if you got a score of 82 or above, that would be an A. If your score, remember, this was out of 50, so obviously you can't have a score of 71. So anywhere from 71 to 81, which means if you had a score of 72 to 80, that would be a B plus. 60 to 70, that's a B. And the vast majority of the class fell into this range here. And then we had, again, 50 to 60, that would be a C plus. We had some students here and a few students down here. And the passing grade was on this, as I say, if it were to end today, would be 38. So if you got a score of 38 or less, that's percentage, obviously, then that would be a fail for the exam and a fail for the course. And after, what I'm going to do is, again, after the second exam, I will recalculate. I will add the two, the averages of the two together, and then again take a look at the exam or the class as a whole. Look at the averages over two exams, and create a rubric. So again, after the second exam, obviously you can go up, you can go down. And so you may see yourself dropping, moving up into one of these or dropping down. I would imagine, again, based on previous years, usually the performance on the second and third exam is a little bit better than on the first exam. But this, I would not be surprised if that just didn't end up being very close to the rubric that I settle on at the end of the course. Okay. Just looking at the overall performance on the exam, there didn't seem, I thought most of you handled the clinical vignettes. I'm sure this was a first for many of you, seeing these kinds of clinical vignettes, but you seemed as a class to handle them as well as the more fact-based questions, which is good, because I think certainly on the second exam, the one, it's not, I think we're 5 weeks away from the second exam, you're probably going to see a few more of those clinical vignettes, just because of the type of material that we're going to be presenting to you in these second units. But again, just keep in mind that a clinical vignette is essentially a fact in disguise. It's content in disguise, right? So, within the context of any of those clinical vignettes is generally just one piece of information, one fact, one thing that you're told that just gives it away, and as I say, and I'll put up some more, like I did for the first exam, I'll put up some practice questions and try to get a few more of those clinical vignettes into the practice questions. I will, if it wasn't obvious to you going into this exam, it should be obvious to you now that certainly the diseases, remember, this is an infectious disease course as much as it's a microbes course. So it's important particularly for these clinical vignettes, that you understand and be familiar with the diseases themselves. So I strongly encourage you to create tables, put together tables of information where you have, the different bacteria listed, the different diseases associated with the different bacteria, the symptoms of those diseases. Obviously, it's the symptoms that you're going to be given. So, how we're going to tell you what the symptoms are. That those symptoms are going to be on slides, the more obvious ones. And so, list those, and then particular features of the bacteria. Are they gram positive? Are they gram negative? Is there a very specific media that they grow on? Is there a specific test that can be used to distinguish between them? Anything that can be used to distinguish between them, you should get and build that into your table as well. And if you do that, you'll find, I think, those vignettes to be quite a bit easier. Okay, are there any questions? Okay, good. So I will, when we get close to the second exam, I will talk about the exam again, and I'll give again more hints for preparing for it, and we'll leave it at that. All right. So now I am recording. You can't hear me, right? Everybody can hear me? Could somebody just pop into the chat that my volume is on and that you can?
You're good.
Yeah, we can hear you.
Great, thank you. Everybody's so quiet. Usually I get like 100 questions after putting up the exam material, but all right. So because I'm the only one on, I am, as I say, recording, but because I'm the only one on, I don't have another faculty member on, I can't monitor the chat. So if you have any questions at all for this next for this next lecture, just feel free to unmute and jump in, okay? And again, if some question arises in your head about the exam and such, we can discuss that at the end as well. I'll stay on for a few minutes for that. So what we're going to do for the rest of the session now is talk about infections of the urogenital tract, which are essentially, for the most part, the infections that cause sexually transmitted diseases. So the diseases are the sexually transmitted diseases. What causes them are things like bacteria. We have examples of viruses that cause sexually transmitted diseases. We have examples of parasites that cause sexually transmitted diseases. So these are the organisms, and the diseases are collectively referred to as the sexually transmitted diseases. We're not going to talk about all of them today because this course, for the most part, is a sampling course. What we want to give you, by that I mean, we just want to give you a few of the more interesting or important examples of the different type of infectious organisms out there and the diseases that they are associated with. Now, it turns out, I'll give you a list, and I think maybe on the next slide, of the different organisms that cause the sexually transmitted diseases. There's not a huge number of organisms that cause them, certainly not as many as cause other kinds of diseases, but the actual numbers of cases that they're associated with is huge. All right, so 13 million Americans affected annually by sexually transmitted diseases, and the majority of them under the age of 24 years. So just a few organisms involved, but causing a lot of trouble. And the main concern about this, what is becoming a really major concern, is that this number is going up. And for a long time, this number was going down. And it started to go down very dramatically in the late 70s, early 80s with the emergence of the AIDS epidemic. And people became very, very conscious about AIDS. And, at that time, long before we know as much about AIDS as we do now, many people considered it to be a death sentence to get an HIV infection. And so, there was many public advocacy, public health campaigns dealing with, protected sex and having protected sex to protect you against HIV. And those campaigns, for the most part, were very, very successful. And a nice, side effect of this, or added bonus to these education campaigns, was that the number of other types of sexually transmitted diseases also went down very, very dramatically. And this continued for decades, through the 90s, 2000, even up to 2010. And then when we got past 2010, and where we really saw this in big time was between about 2014, 2015, we started again to see a dramatic increase in the number of sexually transmitted diseases. And it's really, I think, because AIDS has kind of left the public consciousness. It started to drift away from the public consciousness because it's no longer considered as, say, a death sentence. It's no longer dominating headlines. It doesn't dominate the news anymore. It seems to be something that's brought under control. People are not thinking about it so much. And now we're seeing this increased incidence of young people having unprotected sex. And this, of course, is now being reflected in these numbers. By 12th grade, 70% of, in North America, 70% of, I would call them children still by 12th grades, report in a number of different surveys of having had sexual intercourse. 40%, this is not 40% of the 70%, this is 40% of all kids by 12th grade report they have had 4 or more partners. So that's, obviously to many people, particularly to parents like myself, I have a couple of teenagers, these are extremely alarming numbers, and there's no doubt that these first 2 facts here or observations are intimately connected. Women and children bear the burden of complications, as with most things in life, I suppose. And the reason for this is, as you will see, as we talk about a couple of these more common sexually transmitted diseases, this really relates to the symptomology associated with this infections. And what you'll see is that the symptomology tends to be much milder in women than it does in men. It seems a little counterintuitive, but the thing is that if you have a more aggressive early symptomology, what you're going to get is a much earlier diagnosis. So these sexually transmitted diseases tend to be diagnosed much earlier in men than they do in women. Right? And because of that, they're treated earlier. And if they're treated earlier, you get less complications. So with women, for at least some of these sexually transmitted diseases, the first time they manifest, the first time they're diagnosed, is when they may present as a pelvic inflammatory disease, or a PID. Now, a PID is an infection and inflammation of the upper urogenital tract. And for many of these sexually transmitted diseases, you don't get pelvic inflammatory disease till much later in the infection. So we're not detecting in women these early infections. The first time you realize that you have one of these infections is when you have PIDs. And this is very problematic because PIDs, if they're serious enough, can lead to infertility. If the woman happens to be pregnant, it can lead to ectopic pregnancies. if the woman's pregnant and about to give birth or very close to giving birth, it can lead to infant death or death in the newborn as well. So lots of consequences to this late diagnosis. Also, interestingly, what we're seeing in women more recently, and health specialists, community health specialists haven't really got a handle or an understanding of this yet. But what we're seeing is a large increase in the number of sexually transmitted diseases that are co-spreading in women in the spread of AIDS. All right, now, in some, just looking at that, you would say, well, that kind of makes sense in a way, because somebody who has AIDS is probably not practicing protecting, having protected sex. And because of that, they're making them, maybe more susceptible to these other, infectious agents. And that does make some kind of sense. And people, who do have AIDS tend to be immunocompromised, of course. That's the nature of the disease. So again, you're going to be more susceptible to these other types of infections. So you say, yeah, sure, okay, that makes sense. But the problem is, this hasn't been seen before. Okay, so yes, there is some sort of co-expression of other sexually transmitted diseases with AIDS that has been seen, but more recently, we're seeing a rise in the numbers, a very dramatic rise, particularly in women. And why that's taking place, and why it's particular to women, is simply not understood. Right, so that's sort of an emerging issue. Here's, okay, the numbers and rates of sexually transmitted diseases in the US are increasing. We talked about that. Okay, that's bad news. Lots of bad news on this slide. And again, worse, the diseases are often asymptomatic. So, we talked about early symptomology versus late symptomology. We didn't talk about no symptomology. Many people who get these diseases don't have any symptoms at all, yet they are certainly carriers. So they can spread these, they're unknown carriers. They don't know that they're spreading it, and they can spread it to many different partners. It makes it difficult to track them down, like, through all, if somebody's having a lot of different sexual contacts, it's, it can be very hard to track down the origin of the contact, which was the contact that caused the infection. And to make things even worse, these organisms tend to be very, very difficult to culture, which means it's very, very difficult to study their life cycles, which means it's difficult to get effective treatments for many of them. It's difficult to figure out their life cycles, and unless you know the life cycles of organisms, it's almost impossible to develop vaccines. So we don't really have good vaccines for a lot of these STDs. All right, so these are the STD-causing organisms. I don't have the viruses on here. These, I'm not sure yet whether we're going to talk about viral STD. We're not going to talk about them in this lecture, but later we might talk about them in the viral component of the course. But as you see, it's not a particularly long list. Virtually all of these are bacterial, except one. Trichomonas vaginalis sounds like a bacteria, but that's not. That's actually a parasite. And Dr. Bellafato probably will talk about that in her parasite lectures later. But as you'll see, it's not a huge list. The ones I'm showing you in red are the ones that I'm going to talk about today. That's Neisseria gonorrhea, which is responsible for, as the name implies, gonorrhea. Treponema pallidum, which is responsible for syphilis. I will mention the third one on the list, chlamydia trachomatis, which is responsible for non-gonococcal urethritis. The reason I mention it is this is actually the most common sexually transmitted disease that you'll see in the United States. As I say, this is a sampling course, so I'm just talking about these two today. I'm going to talk about all of them, but say just be aware that there is this third one that's even more common than the two that I'm going to talk about today. One more thing I want to say before we move forward on these, pretty much all of these on the list are not part of the normal flora. All right, so many of the organisms that have been discussed in the course so far are actually part of your normal flora. The sexually transmitted diseases, the organisms responsible for the sexually transmitted diseases, for example, Neisseria gonorrhea, Treponema pallidum, they are not part of your normal flora. So in order to get these, you actually have to have them transmitted to you by somebody else. All right, so they're passed from individual to individual, but they don't normally colonize or form colonies within your urogenital system. All right. So let's begin. We'll talk about gonorrhea first, and then we'll talk about syphilis. So the disease itself has an incubation period of about 2 to 8 days. I don't know if anybody in the course has formally defined what an incubation period is yet, but that's the period of time from the time you're infected to the time that you start to show symptoms. So this is just a range. This doesn't mean that you have the disease for 6 days, from 2 to 8 days. It means the earliest you will show any symptoms, if you are symptomatic, would be at 2 days after the infection, but it could be as late as 8 days before you start the symptoms. And as you see, the symptoms are quite different in men and women. So a man, after about 2 days, would start to experience painful urination, penile edema. Edema is a collection of fluids, so it'd be a swelling, large swelling, profuse discharge from intense inflammation. This is something you would notice, and you would notice it right away, particularly because it's very, very painful. So from the time that you would detect it, from the time, as I said, this will be start about 2 days after the infection, you're probably going to seek treatment almost right away. So we're talking about 1 to 3 days after you start to show your symptomology. You're going to show up in a doctor's office complaining about this, and you're going to start on treatment right away. Okay. Now, same infection, same organism in females, you might see some discharge, some mild inflammation of the lower urogenital tract, but very mild, or in many cases, for the early part of the infection, you can be asymptomatic. All right, and as I say, this is the problem, because what will happen is that the bacteria will then migrate, okay, and deeper into the urogenital tract, and then you can end up with pelvic inflammatory disease, which is definitely more painful. You will be aware of it, but this is the first point at which you might show up at a doctor, with a complaint. And at this point, now you've got additional complications associated with it, particularly, for example, if you are pregnant, and it's much more difficult to treat. If you could catch it at day 2 or day 3, as I say, it would be much easier to treat than this circumstance here. All right, so that's the disease. Sorry, this is the organism, Neisseria gonorrhea. You've already, Dr. Bonneau talked about Neisseria meningitidis back in the first session. So obviously this is related. These are 2 species from the same genus, but they're 2 different species. Gram-negative diplococci right? Kidney bean shaped. Now, this is looking at the bacteria here. You can clearly see that they are diplococci, so they have this slight dumbbell shape to them. People who look at these things a lot, microbiologists, clinical microbiologists, they say that these are often curved and they create this kidney bean shape. There's one there. Personally, I never see it too much. I don't see it as much as other microbiologists do, but that's often how it's referred to in a textbook. So you should be aware of that. I'm certainly not going to show you an image like that on an exam and expect you to identify those as kidney bean shaped, but I might in a clinical vignette say something like, gram-negative diplococci, which are kidney bean shaped, and in which case you would have to recognize that, perhaps I was talking about Neisseria gonorrhea. Meningitis, remember it was capsulated. Gonorrhea is not, so it's unencapsulated. So that's a nice way to distinguish between the two. Remember, and the reason I say you need to distinguish between the two, because both of these bacteria can end up in your cerebrospinal fluid. So both can get into your central nervous system, right? So if you're doing an analysis of a cerebrospinal fluid, you may find yourself trying to distinguish between meningitis and gonorrhea, because that's, as I say, that's where they can end up during their infection. Now remember that meningitis can ferment both glucose and maltose. So gonorrhea also ferments glucose, but it is not capable of fermenting maltose. So that's a very useful test for distinguishing between the two. This is interesting. Gonorrhea is very sensitive to cold and to drying. And this is important if you're a clinician. For example, you have a patient you think is infected. Let's say you take a vaginal swab from them and you want to send that swab to the laboratory and then have the laboratory do an analysis. If you put that swab on ice, right, and send it to the lab and it gets delivered on ice, by the time it gets there, that bacteria will be dead, all right, because it won't be able to withstand those cold temperatures. It'll dry out. And so what that means is if you suspect that it's a gonorrhea infection, a Neisseria infection, what you want to do is you want to take that swab and then you want to put the swab in sort of a warm, humid container and transport it in a warm or humid container to ensure that that bacteria is able to survive the trip. When it gets to the lab, what you're going to do is plate it out on what's called an enrichment media. There's a particular media that we use for Neisseria gonorrhea. It's called modified Thyr-Martin VCN. Now, in a clinical vignette, as I say, that would probably just be referred to as a Thyr-Martin plate. All right, so remember, a Thyr-Martin plate is really a Thyr-Martin VCN plate. All right, as the name implies, this is an enrichment media, which means that gonorrhea can grow on this plate, but a lot of other things can't. So by streaking on this plate, you're enriching whatever your culture is for the presence of Neisseria gonorrhea. And the reason for that is the VCN. What does VCN stand for? V stands for vancomycin. So the plate has vancomycin in it. And vancomycin will pretty much inhibit all gram positives. All right, so remember, this is gram negative, so it'll get rid of all your gram positives. The C stands for colistin. Colistin will actually inhibit a lot of gram negatives, particularly all the enterics, but it won't inhibit Neisseria gonorrhea. So again, that'll get rid of any of the gram negatives on your swab. And the N stands for nystatin. Nystatin inhibits yeast growth. So again, if you take a vaginal swab, that's going to have a lot of different bacteria on it. It's probably going to have some yeast growing on it too. So if you were to just take that swab and spread it on this plate, chances are you come next day, you'll get a plate that's just covered in yeast, because yeast grows so rapidly. All right, so that's how you grow gonorrhea. the enriched media. And if you do it properly, what you'll do is you'll come back and you'll see these little white colonies here. All these little white colonies here are in gonorrhea.
Professor, can I ask a question?
Sure.
I guess it's a two-part question. Would it be possible to treat it with like something like liquid nitrogen, or is it only internal and you can't see an actual sore, so it won't be helpful?
You wouldn't see a sore. So it's
Okay.
not like syphilis,
Okay.
right, where you see a sore, right? And we'll get to syphilis in a minute. That's a little different. Yeah. Was there a second part to your question?
I mean, the second part was, is it a sore? I mean, can you see a sore?
Yeah, no, it wouldn't present.
Yeah.
It typically doesn't present as a sore. I say the same way syphilis does. All right, diagnosis. Well, it's a gram-negative diplococci in your urethral smears. All right, so the diagnosis in males, it's a lot easier, obviously, because I showed you the symptomology. Females is a little trickier, but you're going to be looking for these gram-negative diplococci in these urethral smears. You're going to culture and identify the organism on this enrichment media, and I talked about things like fermentation, what the bacteria actually looks like. Treatment, penicillin. Now, about 20% of isolates are resistant to penicillin. That sounds like a lot, but that's actually not bad. There's very few bacteria out there which at least a certain percentage of the strains are resistant to penicillin, and 20% is about normal. So, you would start with penicillin, and if that doesn't work, you could, there are other choices that you could move to. Multiple drug resistance, however, is starting to become a recent problem, and that's for a long time, the number of cases was really going down in the United States. So we weren't so much worried about multiple drug resistance because we were really bringing it under control. Now that we see this emergence of new cases, we're going to see, I think we're going to see this multiple drug resistance, unless we can bring it under control again, is going to be a problem. All right. Let me just reverse, because there was a slide that I feel like yes, sorry. I'm just backing up, and just for a second, because I just realized there was a point that I wanted to make, and I think when I forwarded slides, I managed to jump over one earlier. This is one of the earliest slides, and this is again just to emphasize this point of what's really started to happen we start to see it in 2014 and 2015. So this is case numbers. Remember, there's chlamydia. That's the most common sexually transmitted disease. There's gonorrhea, and there's syphilis. These were the case numbers that were reported in 2015. And this was the difference. Now, remember, from about 1980 to 2015, these were either flatlined or going down. And flatlined is pretty good when you realize the population is increasing. If the population is increasing and you're flatlining on your numbers, that means you're bringing down your rates. And so the rates were going down. And then, this incredible data came out from the CDC in 2015, and it's really got it just shocked a lot of community-based health workers, right? So we saw this in chlamydia, 6% increase. This came out of nowhere. 13% increase in gonorrhea, and almost a 20% increase in syphilis. And again, that's just to reinforce that point I was just making about the gonorrhea, is that we weren't really worried about multiple drug resistance because the cases were going down. But now, 20% into, I think between 2018, 2019, it was like a 15% increase in cases. So it's not like it was just a one-off 1 year thing. Now these numbers are really going up dramatically. And when you start to see things like that, that's when multiple drug resistance becomes more of a problem. All right, so let's talk a little bit about our immunology or antibody response to a gonorrhea and gonorrhea infection. So if you actually get infected with Neisseria gonorrhea, you are going to mount a very robust antibody response. All right. So, and it's highly immunogenic. So lots of antibodies are produced. And, most patients, you can get them early enough. You can treat them with antibiotics. You can clear them. So in North America, we can, people aren't dying of this for the most part. We can get them onto the antibiotics early enough. We don't even have to worry about sequelae. Then the question is, if you have such a strong antibody response, do you then get immunity? Do you have to worry about it again? And the answer to that is there's no immunity. So even though you have this profound immune response and you make all these antibodies, you cannot become immune to reinfection. So you can be infected over and over again with gonorrhea. And so why is that? And the reason for that lies in two things that this bacteria is able to do, and other bacteria are able to do it as well. It'll come up in subsequent lectures, and it's something even the viruses can do. One is called phase variation, and the other is called antigenic variation.
Professor?
Yeah?
Oh, did we go over the virulence factor?
That's what I think what's happening is as I'm advancing it, it's almost like skipping two steps at a time. So that's why I'm just going back now. Thank you very much for pointing that out. Okay. All right, because it's important that we cover this to understand the phase variation. So let's go back. So let's look back at the gonorrhea virulence factors now. And this is something we've been doing with the different bacteria. We've been pointing out to you some of the more important things that they do, some of the more important things that they secrete or make that allows them to be successful. And as far as gonorrhea is concerned, the one that's probably most important is the pili. And so a pili is a protein that's expressed on the surface of gonorrhea. It covers the surface of the bacteria and it enhances adherence to the mucosal cells. So this is, it's the urogenital tract. So this tract is covered by it's a mucosal surface under which lie the mucosal cells. So this particular bacteria, remember, it's not part of your normal flora, so it gets transmitted. It has to make its way through that mucus, and it has to be able to adhere to those mucosal cells underneath so that it can then pass between those cells and infect. All right. And the pili is one of the factors that allows that to happen. So it has all of these pili on the surface, and the pili will bind tightly to mucosal cells. It will allow the bacteria to resist the shearing. As the urine is very good at flushing out bacteria out of the urogenital system, particularly pathogenic bacteria. And this adherence is so tight because of these pili that's very helpful. So that's one of the virulence factors. It also has a number of other outer membrane proteins, so proteins on its surface. They are also responsible for attachment and penetration, but they're associated with attachment and penetration related to other cells. So we're not now talking about mucosal cells, and we'll talk about what kind of cells they are a little bit later. So it's not just mucosal cells that this bacteria has to attach to. There are other cell types as well. And so to do that, it uses these other proteins. So pili are just for the mucosal cells. Gonorrhea also produces gonobactin. So gonobactin is a siderophore. Siderophores are molecules that bind to iron. So gonorrhea requires a lot of iron in order to replicate. And so it needs to scavenge that iron from us, so the organism that is infecting. So what it does is it actually releases these siderophores. They can bind to multiple iron molecules, and then it takes them up again. Okay, so once they're loaded with the iron, it then engulfs them again in order to scavenge the iron and allow them to divide. And, because they have to get through mucosal surfaces, they have to deal with secretory IgA molecules. So like many bacterial species that, need to infect through mucosal surfaces, they also secrete an IgA protease to cleave those. If as I'm advancing through these slides, I manage to skip one, please somebody shout out right away. All right. So as I say, this seems to be this presentation has a mind of its own today. All right, so I think this is where we got to. So why no immunity? And the lack of immunity is related to the pili themselves. Remember, so those pili that the bacteria needs to bind to the mucosal cells. And gonorrhea is able to go through two different processes. These processes are called phase variation and antigenic variation. And what the bacteria does is dependent upon the strain. Typically, they don't do both. So you'll get some N gonorrhea strains that are capable of undergoing phase variation. And there'll be other strains that are capable of going through what we call antigenic variation. But as I say, in both cases, this is related to the pili. If it is able to undergo phase variation, what that means is the bacteria is able to switch between the presence or the absence of the pili. So it can actually make its pili disappear. All right, so it'll express them, they'll be on the surface, and then suddenly they're not there anymore. Antigenic variation means that these particular strains are able to change the structure of their pili. Right? And that has important implications for antibody response. So let's begin by talking about the phase variation. So, that's what a pileated strain would look like. So this is a strain that is trying to get into the cell. So it's now binding to the mucosal cells. And notice all of these, really are pili coming off the surface of the bacteria, all allowing it to bind very tightly to these mucosal cells. This is what non-pileated looks like. And this bacteria can do this. And when it does this is after infection, all right? So it requires the pilia to get in, all right, through the mucosal cells. But once it gets through the mucosal cells, the bacteria doesn't actually require the pili anymore. And so what it'll do is it'll stop making pili. So as the bacteria divides, it'll stop producing pili and you'll get cells like this. All right, but as I say, it doesn't need them anymore because remember, these bacteria actually have other surface molecules which they can then use to bind to other cell types once they get in. And they are required to bind to other cell types, but not the pili. So think what's going to happen here. The bacteria goes through the mucus, it's got the pili, binds to the mucosal cells, enters between them into the organism, starts dividing. Now, what the first thing that the organism sees, our immune response sees, is bacterial cells covered with pili. And pili are highly immunogenic. So we start producing massive amounts of antibody for those pili. All right. So, right away we have an immune response. We start making all our antibodies now targeted at different antigenic epitopes on these pili. And, we start producing them. As we're producing them, the bacteria is reproducing and it stops making the pili. And so by the time those antibodies are available to attack the bacteria, all they can attack is the original bacteria that came in. But any of the progeny, the new bacteria that have been produced, don't have pili on them. So they're no longer responsive to the antibody response. And that's called phase variation. Okay. And as I say, the bacteria can do this because It doesn't need the pili once it gets it. Now, this doesn't mean to say that the bacteria doesn't need to bind to cells. In fact, we know that the bacteria attaches to phagocytes, all right, which again is a little counterintuitive, right? But it doesn't need the pili to attach to the phagocytes. It uses these other surface molecules. So why does this bacteria bind to phagocytes, which are the cells that it should be trying to avoid? Well, this is one of these types of bacteria that actually can replicate within phagocytes. So it stops producing the pili, it binds to the phagocyte, it gets engulfed by the phagocyte, and now the phagocyte cannot degrade the bacteria once it's in the phagocyte because of the nature of this bacteria. And so the bacteria then starts reproducing within the phagocyte itself and then releasing all of this bacteria from the phagocyte. So it creates these cells, which are just little bacteria producing factories, and it's inside a phagocyte. So it's completely invisible to the host immune response at this point. All right, so that's how phase variation works. Now, we don't really know the mechanism by which it's able to shut the production of those pili off, but they can certainly do that. All right, antigenic variation, these are different strains of gonorrhea, and this is a different tactic that they use to avoid the host immune response. And what happens here is that instead of stopping producing the pili, the bacteria, these strains will continue to produce the pili, but they will change the sequence of their pili by just a couple of amino acids. And they can do this multiple times. So if we look down here at this graph, what we're looking at here now is microbial growth inside an organism. So the organism has now got inside, and we're looking at what's happening over time. So, and the curve is looking at your antibody response. So you go in, okay, this is not phase variation, this is antigenic variation. So the body starts making antibodies like normal against the pili, but in this case, the bacteria is not going to get rid of the pili, it's going to change its pili. Okay, so you get this immune response, you get a lot of antibodies being made. All right, and then these antibodies are going to, and it's going to be sort of an antibody against, we'll just call it pilin or pili type 1. All right, and that's what it comes in with. And that's what we're going to form the antibody response to. And that's now going to attack the bacteria that comes in. But what happens with that bacteria when it comes and starts to divide, and this happens in about, I'd say about 1 in every 10,000 bacteria. 1 in every 10,000 of the bacteria, as it divides, undergoes antigenic variation. So it will change its pili by just a couple of amino acids, and that's enough to alter the epitope such that the antibody you made can't attack that bacteria. So you make antibody 1, it attacks pili type 1, everything's going great, you're clearing the bacteria wonderfully, you've almost got it all gone, but 1 in 10,000, which doesn't sound like a lot, but from a bacterial perspective, that's a huge amount of bacteria. They're not making pili type 1 anymore, they're now making pili type 2. So all the bacteria dies except for this pool that is now completely, cannot be targeted by the host immune response. So what happens? It starts to take over and become the dominant population, right? So now we have, pili type 2 producing bacteria, and your immune response says no problem, okay? New epitope, it's still a foreign antigen, will make a new antibody that now targets this new strain. Okay, so you make an antibody that targets the new strain, and the antibody starts attacking that variant. What happens? The bacteria goes to type 3. It changes it again. And it's estimated the bacteria can do this maybe 20 times right? It can change the sequence. And every time it changes the sequence, you get, this pattern of microbial growth. So here you're going to have disease, you're going to feel better, and then suddenly it comes back, you feel disease again, it'll feel better. You get these waves of disease associated with gonorrhea infections. Now, this is an infection, obviously, that's not being treated. Okay, that's antigenic variation, and not just you'll see as we go through this course, there's other organisms that can do this as well. The organism Bergdorfia that causes Lyme disease, you see the same thing, and you get these, and it's characterized by these waves of disease where you feel like you're getting better, and then you relapse, and then you're getting better and you relapse. And I say Lyme disease is very similar to that. Some viruses can do it as well. Malaria, the viruses that cause malaria will do exactly the same thing. All right, so they'll go through these phases. All right, so let's look at exactly now how the bacteria is doing this. And in order to understand how the bacteria is doing this, we have to look at the genes for the pili. And there are two genes or two loci, what's called pil-E and pil-S. So pil-E, the E stands for expression locus. This is the pili or the pilin's structural gene. So this is a normal gene in the genome. It has a promoter. So here it is here. So here's the pili gene. Somewhere here is probably going to be a promoter. There's a promoter here that's going to drive the expression of this mRNA, which is going to produce this protein, this pili protein. The protein itself has two domains. It has what's called the conserved domain. This is the domain that anchors this protein into the membrane. And then we have the extracellular. This is the piece that's dangling off the surface. This is the antigens. This is what's developing the antibody response. And we call this the variable region. So this is the pili locus and the the pil-E locus, and the bacteria is going to have one of those. Okay, in its genome. Now see these slashes here? These slashes mean far, far away in the genome, somewhere else. What we find is what we call the silent pil-S loci. So the S stands for silent, and there's about 10 to 15 of them. There's been a number of genome sequences. Now, some people now estimate there may be as many as 20 or 25 of these. Some are clustered together, some are individually, but they're spread throughout the genome. They don't have a promoter associated with them at all, so they're not expressed. They don't make mRNAs, but what they are almost, the important word here is almost, precise copies of part of this variable region of pil-E. Okay, so what will happen is this is what you're making as you come into the organism, as you infect. And then, antibodies will be raised against antigens within this variable region. And so what will happen is in about, again, 1 in 10,000 bacteria, as that bacteria starts to replicate, about 1 in 10,000 bacteria they'll start with pil-S1 here. They'll use it during a round of replication. They'll use that as a template, okay, and copy that pil-S1 into this variable region, all right? And pil-S1 will have maybe 2 or 3 nucleotide differences, which would cause 2 or 3 amino acid differences or changes. All right. And it's called RECA-mediated recombination. There's a recombination involved here, but the outcome is more like a gene conversion. You essentially take this region and take those few amino acids that those differences here and convert those amino acids into the amino acids that are in here. You end up with something that looks like this. And the reason it's called it's a gene conversion rather than a recombination is because this never changes. This just stays the same. So it's really just used more as a template. And so now you're producing this. And this is pretty much identical to this, except those couple of amino acid changes. Okay. Then, as I say, the body will start producing antibodies to produce, we've got new epitopes here. The structure of this has now changed. We're going to make, so we'll change our antibodies. Now we'll target that. As we're targeting that, 1 in 10,000 bacteria do the same thing again. They make a swap in the same region, but what they do now is they bring in PIL-S2. So PIL-S2, somewhere else in the genome, has a couple amino acids different, but it's different amino acids, not the same changes here. So it will now swap in. PIL-S1 disappears, and so you're going to pull PIL-S2 in. And then next PIL-S3 and 4. Now, as I say, this can happen 15, 20 times. And every time it's like the bacteria is just staying that one step ahead of your immune response and avoiding those antibodies. All right, let me just pause for a second for questions.
Yeah, I have a question. In case
Sure.
of antibiotics, do they target specific like phase variation or antigenetic variation? Or I'm wondering, how does the antibiotic work?
Oh, the antibiotics, like this is what happens, okay, if you don't treat, okay? So this is a person who's not being treated at all. And there are many places in the world where you can't get treatment. So that is how this disease would manifest itself. This has got nothing to do with antibiotics. It's really just due to your host's immune response. If you've got the antibiotics, you're going to treat them with antibiotics, and they can do this all day, and it doesn't matter. It doesn't make them resistant to antibiotics at all, okay? It just makes them resistant to your host immune response. Is that clear?
Very clear. Thank you so much, Professor.
Okay. Is everybody else good with this? It does. Okay, well, we'll keep going. As I say, if it's confusing your head and you want to formulate a question, we can get back to it later if you like. All right. Let's make sure I didn't miss anything. All right, so that's gonorrhea. Let's now move on to the second organism we're going to cover, or the second disease, and that is syphilis. So syphilis is caused by a different bacteria, obviously. This is Treponema pallidum. These are gram-negative spirochetes. Now, notice I put gram-negative in parentheses here because, whenever we say gram-negative, gram-positive, the implication is that you could use that to help in your diagnosis. So you could do a gram stain and help in your diagnosis. The reality is, though, you would never gram stain this organism. If you did gram stain it and you put it under a very powerful microscope, you might be able to see, it is gram negative, and you might be able to see that, but they're so long and so skinny that you can't see it under the kind of microscope you'd need to evaluate it, right? So that's not useful. So that's why I put it in parentheses. It is, it's 2 gram negative, but that's not how we identify it. We don't use a gram stain to identify it. We don't use a gram stain certainly to determine which species we're talking about, anything like that. They're spirochetes, I say, very long, very thin. And so we generally just look at them in a dark field microscope. So this is a dark field. So we use very specialized type of lenses, specialized type of microscope, and see how long they are. And they look like, they almost look like pasta, right? So these long, skinny pasta. They do possess an outer membrane. Well, they are gram negative, so that's not surprising. They possess an outer membrane, but it's a little unusual in that their outer membrane doesn't contain LPS. So that's a little interesting fact about them. They also lack many of the major biosynthetic pathways, which means that you can't just really streak these on a plate and they grow nicely. There aren't very many plates. You can take a clinical swab and put it on a plate and certainly find these, but you can't grow them up that way. You can't grow colonies on a plate and study them. Syphilis is, Treponema pallidum is actually cultured in rabbit testicles. This has been around forever, and it's still the most common way in which this organism is actually cultured. So you have to inject it into the testicles of rabbit. You can grow it up to high concentrations, and then you can isolate it and study it in that way. But that, let's say, makes it very difficult to understand the life cycle, makes it very difficult to identify targets for drugs and targets for vaccines. It has a flagella, but the flagella is interesting because it's present in the periplasmic space. Now, most bacteria with flagella, the flagella just kind of like hangs off the side of the bacteria, and it spins like a propeller and propels the bacteria forward. The periplasmic space, that's the space between the outer and the inner membrane. And then what these organisms have is that flagella runs between those membranes from one end to the other. What that means is the whole organism is essentially a flagella. So the whole thing, just think of it like a corkscrew spinning, and it's the whole thing is sort of propelling itself forward. So it's very, very unique mechanism, something that's unique to the spirochetes. All right, let's look at the disease a little bit here, because there are, again, we're talking about, what happens in the disease if the disease is not treated. Just following up, I haven't missed any slides. Is that correct? Did I should. Just going back to everything. We did treatment and gonorrhea. All right, I just worry that, okay. All right, good. So different stages of syphilis disease. As I say, this is based on the presumption you have an untreated case. How would this case proceed? So you start with the infection, all right? And like many organisms, you get growth of the organism at the site of infection. So that's what happens with T. pallidum. So you have a fairly aggressive growth at the point of infection, which is generally the genitourinary tract or region. And then we get dissemination to all different tissues throughout the body. And this includes the central nervous system, okay? And so that's sort of that's the big story there. There are virtually no, if this is left untreated and it's aggressive and it's symptomatic, there is virtually no organ in the human body that this bacteria will not infect, will disseminate to and infect. And as I say, that includes getting into your central nervous system. So it will show up in the cerebrospinal fluid. Okay, but that's not to say this happens with everybody. All right. So you start with the infection, you get localized growth, and that's going to start. The first stage of the disease is what we call primary syphilis. And the incubation period, remember I described what an incubation period is about 3 to 90 days. So you're going to start at the earliest you'll show symptoms is about 3 days, but it could actually be 3 months from the time of infection that you start to show your symptomology. And the symptoms of primary syphilis are a chancre. So somebody else was asking earlier about sores. In syphilis, the primary expression of primary syphilis is a chancre at the site of infection. All right, so there will be a sore. Okay? Something else you will see is what's called regional lymphadenopathy. Now, lymphadenopathy is swollen lymph nodes. Now, when people get infected with bacteria, viruses, one of the responses is, where you're going to fight that infection, or your B cells, your T cells get activated, is in your lymph node. So you get generalized lymphadenopathy from an infection. All your lymph nodes become engaged. But what's unusual about syphilis is if there happens to be some lymph nodes close to the site of the infection, you'll get very specific swelling of those particular lymph nodes. And that's what we call, regional swelling of regional lymph nodes. So it's unusual. All right, that's 30 to 90 days. Untreated, it will then progress to what we call secondary syphilis. And that's the earliest that will start is 2 weeks, but again, it can be up to 6 months before you get that. And when you progress to secondary is obviously very much dependent on when you get primary syphilis. If you have to have primary before you can get to secondary. So if you get primary after 3 months, you're not going to get secondary after 2 weeks, right? It's going to be somewhere between 3 months and 6 months. So when you get secondary is determined by when you get the primary. And now it's much more disseminated. Now you've got a disseminated infection. So it's now spread through your body. You're going to get a disseminated rash, kind of a spotty rash. This rash can be all over your body. In some cases, you always get the rash, right? So all over your body. But if it's not all over your body, at a minimum where you would see it is on the bottom of your feet and on the palm of your hands. So you have these red spots over the palm of your hands. I'll show you what this looks like in a minute. Fever, malaise, lesions on mucous membranes throughout your body. And remember, it's going to get into your central nervous system. So you're going to get meningitis. That's the headaches is what's going to give you the meningitis. And now you're going to see generalized lymphadenopathy. So now, since the infection is disseminated throughout your body, all your lymph nodes are going to be swollen. Okay, after that 2 week to 6 month period, the next phase is what's called latent syphilis. All right. Now, in these two stages, primary and secondary syphilis, you're highly, highly infectious. Once you leave that and enter what we call latent syphilis, you're no longer infectious, and your symptoms can actually all go away. All right, so you're still infected, but you essentially get better. You become almost totally asymptomatic. Now, if you enter latent syphilis early, and by early I mean less than a year from the time of your primary infection, right? And that's considered early. Then there's about a 25% chance that you can enter latent and go back into secondary. So it can reverse. You can have another bout of secondary syphilis, and then go back into latent. So this step is reversible if you enter latent very early. If you enter latent syphilis late, say about after a year from the initial infection, that's very unusual to go back. So you would just stay in the latent phase. All right, so latent is you're not infectious and you're now asymptomatic. All right. Now, what happens next is, again, depends on your luck, right? So in about 70% of cases, you're good to go. No further complications. So you're not infectious anymore. You have no symptoms anymore. You still have the bacteria in you, but no further clinical problems. About 30% of cases, however, will progress at some point into tertiary syphilis. Right? And tertiary syphilis is a real problem. This is where you do not want to get to. And this is where all the ugly pictures come from in health education classes and, public health campaigns and things like that. This is cardiovascular syphilis. So it will express in the heart. It can destroy tissue in your heart, causing heart attacks. It can destroy tissue in your central nervous system, which can lead to personality disturbances, confusion, dementias, delusional states. And you can get what's called gamma. Gamma is very large, non-cancerous growths of tissue. They look like massive tumors. They can be anywhere in your body. They're massive growths, but they're sort of a soft tissue, but they're not clonal. They're not cancer. They're just, as I say, these large tissues, but, they can be very disfiguring, and they can be, sometimes physiologically, they can be problematic depending on where they form. All right, so this is, again, I'm just going to reiterate what I just said. Different stages of the syphilis disease. Stage 1, primary syphilis, 3 to 90 days. I think the previous slide may have said 2 to 90 days or something. It depends on where you pull your figure from. They may be plus or minus a day or two here or there. But stage 1 is the earliest stage, and it starts off with this chancre or this sore, generally in the urogenital area. Stage 2, 4 to 10 weeks after the infection. Then you get this body rash. There it is. It's almost always on the hands, on the bottom of the feet as well, but it can also be on the body itself. So if we look over here, there it is on somebody's back. There it is on somebody's hand. So that's secondary syphilis. Now, between stages 2 and stages 3 is latent syphilis. All right, so don't mistake latent syphilis with tertiary syphilis, or what's called sometimes stage 3 syphilis. That's between the two. So between stage 2 and stage 3, latent, you're asymptomatic, non-infectious. This is non-infectious. This is this is infectious. This is infectious. This is infectious. This is non-infectious. And if you're one of those 30%, you're going to end up here at stage 3. This can be 3 to 15 years after that initial infection. And again, it's going to affect a lot of different internal organs, particularly cause a lot of damage to the brain, a lot of damage in the heart, and it can certainly be lethal. Okay. Tertiary syphilis, again, tissue destruction due to the host response. So the actual amount of bacteria, by the time you get to tertiary syphilis, if you're unfortunate to get to that point, the amount of bacteria left is really, really small, okay? It's really hard to even detect them, the bacteria at this point, but it is there. All that tissue destruction that's going on is not the actual bacteria, it's the host's immune response trying to clear infected cells. All right, so the amount of bacteria per cell is very, very low. So there's just a lot of tissue damage, as I say, going on here. You'll see these cutaneous, these gammas or these gammatous lesions. We talked about cardiovascular, central nervous system. Those, no organs are spared, but these are the ones that are going to kill you the earliest. The damage, for the most part, is irreversible. Okay, so once you get into tertiary syphilis, you can use those antibiotics, but it's not going to work particularly well. Congenital syphilis is a particular problem. All right, so this is if you have a mother who has syphilis and passes syphilis to their newborn at birth, this can manifest in 2 ways. You can see it very early, what we call early congenital syphilis, where you start to see symptomology earlier than 2 years of age, or sometimes you don't see any problems until after 2 years of age, and then you start to see. But when you see the symptomology, it's like tertiary syphilis. It's very, very problematic. About 50% of cases result in stillborn children. All right, so that's, obviously a big concern. So in North America, we generally catch these things, we treat them early enough, but there are a lot of places in the world where we don't. Diagnosis, bacteria visualized by dark field and silver stain. So although I'll say theoretically we can use a gram stain, the reality is you're just never going to see this under a normal microscope that would allow you to see a gram staining. So we use a silver stain, and you see these. I show you an example of that area earlier. Agglutination. Okay, so we certainly have antibodies for syphilis, so we can use these latex beads. We can coat them with antibodies specific for the treponema, and so we can utilize an agglutination reaction. If you get to tertiary, where it gets, the amount is so small, you're just probably not going to be able to get enough out of the individual to have a successful agglutination reaction. So you're probably going to have to do a PCR reaction. But to tell you the truth, tertiary syphilis is when you get it, it's pretty obvious. So it's really just confirmatory. PCR is a little bit more expensive. You don't want to be doing a PCR test unless you have to, but that can be sometimes the only thing available to you. Treatment, penicillin. Don't worry about the G, just the treatment is penicillin. Syphilis can be treated, but boy, you have to get to it early. If you get to it early, no problem. You can prevent tertiary syphilis from forming. You can completely wipe this thing out, complete absolute recovery. Even in secondary syphilis, you can, even treatment there is fine. Once it gets to tertiary, however, remember the damage is not being caused by the bacteria at that point. It's just it's an overactive immune response, and that's something that penicillin is not going to have any impact on. And I think that's it. Okay. Let me come out, and if anybody has any questions, feel free to unmute and fire away.
Yeah, Professor.
Yeah.
Someone had mentioned something about antibiotics during the vigorous antibody response.
Yes.
Yeah. Can you explain that again? Did you say that antibiotics can prevent these mechanisms, or what was it that you said?
Is this when we were talking? Are you talking about gonorrhea when we were talking about the phase variation?
Yes. Yeah.
Okay. Yeah. So somebody asked whether the phase variation, as I understood the question, they were asking whether the phase variation would provide an antibiotic resistance. So would it affect how useful the antibiotics are? And the answer to that question is no. Okay, so the effect of the antibiotics is completely independent of the phase variation. It's got nothing to do with the pili. So the antibiotics would kill the bacteria no matter what pili they're expressing. What I was showing you is what happens when you don't treat at all. So you have a patient who's got the gonorrhea infection, okay, but they're not being treated with antibiotics at all. So they're relying on their host's immune response to respond and clear the bacteria. And it's showing why, because of this antigenic variation, why the host immune response doesn't work. And the fact that it doesn't work means we have to use antibiotics. If the host immune response can clear it, that's great, but it doesn't because of this. And so you have to use the antibiotics. If you use the antibiotic, get the antibiotics in early, the bacteria can do this all day. It's not going to protect it against the antibiotics. Okay?
Thank you.
That makes sense?
Yes, perfect.
Okay, so don't get the two things mixed up. This is, we're not talking about antibiotic resistance here. We're talking about resistance to the host's immune response, all right, to antibodies. I apologize what was going on with my slides there, just jumping ahead and jumping back and stuff. But I do think I managed to catch them all and touch on the salient points of all the slides. Okay, good. I think we're fine. Thank you very much, everybody. Looks like we're finishing up nice and early today. Wonderful. Makes a nice change. So enjoy the rest of your day. Reach out to me if you have any questions at all, and I will see everybody next week. I will, as I say, as soon as I get, I'm hoping to go to look at my email now and have a note saying, all the names have been clear, sorted out in the educational management system. As soon as they are, I'll release the grades for everybody. Okay, and I'll send out an email. So we'll see everybody next week. Take care.
Have a good night. Thank you.